Thank you for joining us today for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Jonathan Haydak, and I am an AAKP Ambassador for the state of New York. I work at Mount Sinai in New York City in the Department of Nephrology. I am a PhD student under the mentorship of Dr. Enver Azaloglu. My main research is focused on understanding mechanisms of kidney damage that are shared across various kidney diseases. On World Kidney Day in 2019, I received a kidney transplant from my sister Rachel. Prior to that, I was on dialysis for almost 3 years, and I have done both peritoneal dialysis and in-center hemodialysis. My experience as a patient actually inspired me to change my career trajectory and get into kidney research. Being both a patient and a researcher has really given me insight into how important it is to have patient involvement to help direct and guide research. Being a part of an organization such as AAKP really amplifies my voice as a kidney patient. Throughout the years, AAKP has been crucial in accomplishing a lot for improving the life of kidney patients, and they are always at the forefront fighting for patients' rights. I think it is unfortunately often the case that patients are left out of the research and innovation process, and this has been especially true in kidney care. I am glad that AAKP has made major strides in patient inclusion and generally pushing for innovation in general. KidneyX, the Kidney Precision Medicine Project, these are all things that are very much needed in the kidney space, and they have significant patient involvement in large part due to the efforts of patient organizations such as AAKP. Today, I am pleased to introduce AAKP friend and ally, Dr. Enver Akalin, Professor of Clinical Medicine and Surgery at the Albert Einstein College of Medicine and Medical Director of the Kidney and Pancreas Transplant Program at Montefiore Medical Center, for our session on top health concerns, COVID-19 implications on transplant patients. Thank you for joining us today, Doctor. You may start your presentation.
Hi, I would like to thank the organizers for the kind invitation to share our experience COVID-19 in kidney transplant patients. And as you know, in New York, we were the first at the peak of the pandemic and probably the most experienced with the COVID and kidney transplant patients that I would like to share. So these are my disclosures, but for this particular presentation, I have nothing to disclose. So as you know, human coronaviruses is common viruses that cause non-specific upper respiratory tract infection, and especially the 4 types are the most common. But as you know, the problem was with the end of 2019, identification of the SARS-CoV-2 and the COVID-19 disease changed how we live and how we travel, and it was probably one of the most difficult times in humanity in 2020. The first case in United States was in January 2020, and at our center, March 11, 2020. So in terms of the COVID-19, the 80% of the patients, it is mild constitutional symptoms, fever, dry cough, and they do not need specific medical attention and do not require hospitalization. 20% of the cases that patients may go to the second stage, pulmonary phase, started to have shortness of breath. They may require oxygen treatment and hospitalization. The chest imaging has typical findings of COVID-19 pneumonia. I believe that most physicians are very familiar with the chest X-ray or chest CT findings of COVID-19 pneumonia. And unfortunately, the further problem in stage 3 happens in 1 to 5% of the patients might go to inappropriate inflammatory response phase with the increased elevated inflammatory markers and multi-organ failure from kidney failure, heart failure, or liver failure. So this is how we respond to the virus. As you see at the left top corner, there are two receptors for the SARS-CoV-2, which is ACE2 or TMPRSS2. And after the viruses bind these receptors, it replicates at the upper respiratory cells. How do we respond? Normally, the initial response is through the innate immunity, as you see at the bottom right side. Alveolar macrophages clear up the virus and they are neutralizing the antibodies. And even without the adaptive immunity, we can clear the virus without systemic distribution. Then later, adaptive immunity may take place, and CD8 positive T cell directly recognize and eliminate the infected cells. And then the CD4 T cell mediates efficient immune response and stimulates the B cell antibody production. And in a healthy immune response with the collaboration of innate and adaptive immune system, CD4, CD8 cells, B cells, antibodies, the virus is cleared. And the problem that you see here at the left bottom of the slide, dysfunctional immune response with the systemic cytokine storm, especially driven by interleukin 6. So what about the kidney transplantation? What should we do at the peak of pandemic with COVID-19? Of course, we all know that the kidney transplantation reduces the morbidity and long-term mortality and is cost-saving, of course, compared to dialysis, but not really an immediate life-saving procedure compared to heart, liver, or lung transplantation. And at the time of the peak of the first peak and observed at March, April 2020, the transplant societies decided to postpone the living donor kidney transplantation, and maybe the deceased donor transplantation can be done in patients like requiring especially in patients highly sensitized, more than 98% panel reactive antibody titers, or lacking options for dialysis access. This is how our cases at Montefiore Medical Center, Bronx, New York. So our first case observed in March 11, and at that time we held the living kidney donation. On March 16, 2020, our first kidney transplant patient admitted to the hospital with diagnosis of COVID-19, and within a week, we held the deceased donor program, and only one patient received combined liver kidney transplantation due to very high MELD score and could not survive waiting the pandemics. As you see at the four hospitals of the Montefiore Medical Group, we had peak on April 13 with almost 2,000 patients, and we do not have any ICU bed or regular bed to admit the new transplantation. So it was not feasible to perform kidney transplantation at the peak of pandemics. So this is the slide, what the programs did in March and April 2020. As you see, in France, almost 90% of the transplantation decreased, mainly coming from kidney transplantation, and the nationwide almost held the second half of March. In United States, the transplantation decreased 50%, but not completely held, because it was first started at the east part of United States and there wasn't a big problem most of the country in April and March 2020. So what should we do, or what we did when the patients admitted with the COVID-19 and the chest x-ray findings of pneumonia? We just took care of the routine blood culture, urine culture, and we add inflammatory markers because it was very important for the progression of the disease, like ferritin, D-dimer, C-reactive protein, fibrinogen, serum IL-6 levels. We look at procalcitonin, if there was secondary infection or not. And we look at at our transplant patients' CD3, CD4, CD8 count, and also look at the fungal urine Legionella strep antigen to rule out secondary infection. So what did we do for the immunosuppressive treatment? If it was mild cases, no viral pneumonia or not requiring much oxygen, we kept the tacrolimus trough levels 4 to 6, and mycophenolate mofetil or mycophenolic acid, we decreased the dose significantly and continue prednisone 5 milligram. If the patients move to the moderate disease with requiring higher doses of oxygens, we held the MMF or MPA, and in severe disease, especially with low CD3, CD4, CD8, we held all immunosuppression, including tacrolimus, and give dexamethasone 6 milligram daily for 5 to 10 days. Because we have the most experience and we immediately want to share our experience worldwide, and it was published at New England Journal of Medicine. So this was the first series of COVID-19 in kidney transplant patients. So we had initially 36 patients, and the majority deceased donor transplant recipients. We are in Bronx, so as you see, the majority of our patients are African American, like 40%, and 40% Hispanic, and they have additional comorbidities such as 94% hypertensive, 70% diabetes, and BMI, mean BMI was 29.3. And of those 36 patients, 28 patients admitted to the hospital, and then the 8 patients were observed at the home. As you see, the only 58% of patients had fever, maybe having the immunosuppressive medications. Not all patients had fever, and also at least one quarter of the patients had diarrhea. And what we did was the majority of the patients, 86% withdrawal antimetabolite and 21% withdrawal of tacrolimus. And at that time, we treated with hydroxychloroquine, azithromycin, leronlimab, tocilizumab, or high-dose the steroid. But this was at the first phase, and as you know, it wasn't effective, and we didn't use, after these cases, hydroxychloroquine. And as you see here, especially I would like to mention that the CD3 count, for example, the patients, 70% have low CD3, 70% has low CD4, the 80% were lymphopenic, and has increased D-dimer, C-reactive protein in the majority of the cases. And during the 3 weeks of our outcome, unfortunately, we lost 10 of our patients, which makes mortality 28%, and 21% require renal replacement treatment, and 40% require intubation. So after this experience, we had Tango International Transplant Consortium. This is mainly to monitor the post-transplant glomerular disease. We had previous publications about the post-transplant FSGS or IgA nephropathy. So we reach those centers, mostly in United States, but some in Italy and Spain, like how they did and how worldwide the outcomes of COVID-19, which was published at American Journal of Transplantation. So at that consortium, there were 144 patients, and half of them had acute kidney injury, and 30% require intubation. And again, like our experience, the mortality was 32%, very high at a median of 52 days. And especially the mortality was associated with the older age, and then high respiratory rate, and then the low EGFR and high IL-6 levels. So now I would like to share our center experience, which it was published at Kidney International a few months ago, and currently we almost follow 1,500 kidney transplant patients, and 132 patients tested positive, diagnosed COVID-19 by RT-PCR. And in May, like approximately 2 months after the first case, we started to screen our patients with IgG antibody to SARS-CoV-2, 912 screen, and 69 of positive patients had already diagnosis of RT-PCR, but 97 patients diagnosed IgG without previous diagnosis of RT-PCR, which means that those patients did not have any symptoms, which was the case one-third of the patients, and two-thirds of the 97 patients, they had mild symptoms. They did not seek medical attention. And when we look at the patients who had the diagnosis of COVID-19 by RT-PCR, 80%, when we look at the around 1.5 months after the diagnosis, they had antibody, but 20% they didn't have antibody. And when we tested the positive patients, 7 of them, and they were still positive. And when we look at the 97 patients who tested positive, 11 were retested and 90 remained positive. So this was the first experience to see how the kidney transplant patients diagnosed by antibody alone and how they respond to the disease. Briefly, I can show that how our peak was. The first week of the March 11, as you see, there were 16 cases, and 4 weeks later, we had 33 patients. So these 7, 8 weeks, I believe, probably our most difficult time as a physician. But as you see, the peak gradually decreased over time. So overall, when we look at our patients, the prevalence of the COVID-19 was 23.4% in patients who were tested by RT-PCR or antibody, and 229 COVID-19 patients were followed for a median of 140 days, and overall mortality was 20.5%, and in hospitalized patient, it was 38%. So when we look at why some patients died and what are the predictors, and also why some patients diagnosed by RT-PCR and they were sick, admitted to the hospital, but not the others. They didn't even come to the hospital. So the next slide, I think this is will summarize the finding because the multivariate analysis is important. So diagnosis by PCR, especially associated with the age, there was a 21% increase for every 5 years increase in age, and also the creatinine level. If the creatinine is higher, 7% increase in mortality for every 0.1 unit increase in baseline creatinine level. And the predictors of mortality, again, the most important factor was age, 48% increase for every 5 year increase in age. And then the deceased donor recipients had a higher risk compared to living donor recipients. And interestingly, patients who did not receive influenza vaccine previous year had an estimated risk of 1.13%. And this could be due to trained immunity. It was shown that if you receive regularly the vaccination or frequent upper respiratory infections, maybe they will respond. Your innate immunity and adaptive immunity may respond better to the SARS-CoV-2. And when we look at the patients, the peak values of the laboratory values, survivors and non-survivors, definitely the patients who died had more lymphopenic, higher C-reactive protein, and then the IL-6 levels, the dimer levels, but especially statistically, the main factor was IL-6 levels. Every 10 unit increase in serum IL-6 levels was associated with 3.6% increase in the odds of death. So our experience at the moment, we can summarize that the 23%, and then the mortality was associated with older patients and high serum creatinine. 80% of the COVID-19 diagnosis patients at the mean of 44 days, they developed the antibody. And 23% of hospitalized patients require renal replacement treatment, and 6.3% lost their allograft. And lymphopenia and low CD3, CD4, CD8 counts are common in kidney transplant patients, and increased inflammatory markers observed, especially the IL-6 levels. And we did the review article, which was published in Transplantation, to review all the published studies, just to compare what happened in the same city, the New York hospitals like Cornell, NYU, Columbia, and Northwell. And at the Columbia and Northwell, the mortality was 30%. In some centers like the Cornell and the NYU, it was lower, around 13 to 14%. And some reported as the solid organ transplantation, the combining kidney, liver, heart, and lung transplantation. The biggest series was from University of Washington Registry, 482 patients, and their mortality was 19%, and in hospital mortality was 21%. Again, in all the studies, the older age is the most significant predictor for the mortality. So when we look at what happened to the general population, so this was the question that I received after our New England Journal of Medicine paper, that is transplantation is absolutely a risk factor compared to general population. Here, this is the largest series from New York, over 205,000 patients with the confirmation of the COVID, and especially it was associated with the age. Like if you are between age of 45 to 64, it was around 4.8%. 65 to 74, it increases to 14% if it is over age of 75. So definitely increasing age, but even for those age of 75 years, the mortality is 14%. Again, it is still lower than we observe in kidney transplant patients. So what happened compared to dialysis patient? I think our best comparison is our center at Bronx, 114 end-stage renal disease patient. Same the demographics, 90% hypertension, 90% African American or Hispanic, 67% diabetes. The in-hospital mortality was 28% in end-stage renal disease patient, and the inflammatory markers were high in mortality. So unfortunately, I do not want to spend much time, but what could be the options for the treatment? And unfortunately, the most studies come as negative studies. It could be the hydroxychloroquine or antiviral agents, lopinavir, darunavir, and then remdesivir, favipiravir, and especially remdesivir maybe in selective cases might have some benefit, but most became a negative study. IL-6 inhibitors as well. So this is the biggest study, over 400 hospitals in 30 countries and more than 11,000 using the remdesivir, hydroxychloroquine, lopinavir, or interferon. Again, this study was reported as negative. And the other thing that we try to give the convalescent plasma, there are multiple papers, but just to show one of them is in New England Journal of Medicine. Again, overall mortality was not different in patients receiving convalescent plasma. And dexamethasone in hospitalized patients. So this is the only study, like the incidence of death was lower, 29% compared to patient who received dexamethasone treatment, 41%, if they receive invasive mechanical ventilation or the receiving high dose oxygen treatment. This is why after this study outcome, we use dexamethasone in our moderate to severe cases. And I do not want to give the details, but the inpatients, mild cases that they do not require hospitalization, there are 2 neutralizing antibody treatment, and both studies show that there is a significant decrease if the patients receive antibody treatment for admission to the hospital, and even the mortality, like giving 53 patients the neutralizing antibody treatment can prevent one death. This is the other current our standard of the care in mild cases to give neutralizing antibody treatment. So this is the slide that I show you that at the beginning of April we did peak, and then gradually at the end of the May it decreased, and we open our program, first leaving transplantation and then the follow-up with deceased donor transplantation at the end of May and beginning of June. So the other important thing is right now, this is the hot topic, the response to vaccination. As we know, it is very effective in general population, almost 100% antibody development to spike protein and 93-94% preventing the COVID disease. But unfortunately, the in kidney transplant patients receiving half Pfizer, half Moderna, after the first dose, this is only response after the first dose at a median of 20 days. Unfortunately, the antibody developed only in 17% of the patient. There were also another follow-up studies. It's a small study, 39 healthy controls and 26 dialysis patient and 39 kidney transplant patient. Only one of 39 kidney transplant patients 8 days after the second dose develop antibody, which was higher in dialysis patient. It was 85%. So which shows also the importance of vaccinating our patients before the transplantation. And another study as well, 87% of waitlist patients had response, but only 6.2% kidney transplant patients. And then another study confirming the similar outcome of 11% response rate after the first dose of mRNA vaccination. And we had another the review article. They ask us what is the risks and benefits of kidney transplantation during the COVID pandemic, and it is in press right now at Kidney 360. So when we look at the studies, the incidence of COVID-19 in waitlist patients is slightly higher compared to COVID-19 patients. But when you look at the mortality, in most of the studies, mortality is higher in transplant patients, 20% versus 13% at the first study, the second study 26 versus 10, and the third study, the Hillbrand's 30%, 5%. Only one study from New York, it was lower in transplant patients, but again, the other studies mostly documented the higher mortality, and especially at the peak of the pandemic, to avoid the heavy immunosuppression, probably these suggest that to halt the transplant would be wiser at the peak of pandemic. So how we will assess the donor, whether it is deceased or living donor transplant, that should be assessed at each center based on the COVID-19 pandemic severity at their region. And in deceased donor transplantation, definitely we need to have a confirmation of the SARS-CoV-2 negative by RT-PCR, and at least within 3 days of procurement, maybe a second test within 24-48 hours. And if the donor had previous history of COVID-19, there should be at least 30 days passed after symptom resolution, and the chest CT should be negative for COVID-19 suspicious lesions. And consideration should be given toward ensuring lower cold ischemia times to minimize late graft function, because if we do disease transplantation, we keep our patients at the hospital until the delayed graft function is improved. And for living donors, again, at least 30 days should have passed after all symptoms were resolved. So what about the recipient assessment? I think with all the data I presented, probably patients over age of 65, especially if they have additional comorbidities such as cardiovascular disease, diabetes mellitus, probably transplantation could be deferred at the peak of pandemics. And transplantation in highly sensitized patients with use of anti-thymocyte globulin or rituximab should be assessed case by case, considering recipients' age or other comorbidities, HLA matching, mismatching, and the severity of the pandemic. And for recipients who had recent COVID, at least 30 days should have passed, and after they are clinically completely resolved, still to have updated cardiac and pulmonary function assessment is considered. And again, the patients ideally should be vaccinated for SARS-CoV-2 before transplantation. So this is just my last slide to conclude the talk. Kidney transplant program should be held during COVID pandemics at regions with high prevalence and incidence of COVID cases. Probably we should avoid not to use thymoglobulin, as I mentioned, that our patients, if they have COVID, has very low CD3, CD4, CD8 count, and you know that we needed our CD4, CD8 cells to fight with the virus, and immunosuppression treatment should be minimized. And at the moment, it is not clear how antiviral and anti-cytokine agents should be used. There is no documented study. Definitely no indication for hydroxychloroquine. And neutralizing antibodies could be used in mild cases, not requiring admission. And dexamethasone treatment for 5 to 10 days in moderate to severe cases. And kidney transplant program should be slowly resumed after COVID-19 pandemic subsides, with a careful and thorough selection of recipients and donors, and patients encouraged to be vaccinated before transplant. And for our patients after the transplantation, we advise them 3 months after the transplantation to get vaccination. Thank you very much for your attention.
We appreciate Dr. Akalin for taking the time to share his insights and expertise. Thank you.